Okay, welcome everybody to this week's CBP Nonprofit Video Research Review. I'm Dr. Deed Harrison. I'm president of Chiropractic BioPhysics Seminars and Technique, but I'm also president of Chiropractic BioPhysics Nonprofit, which is our research foundation. For those of you that don't know, they're two separate entities. We have a seminar training service for chiropractors, and we also have a research organization where we actually test and present new ideas, new concepts, and old concepts for spine treatment for patients with a variety of health disorders. What I'm doing in these weekly videos is I'm reviewing each one of our peer-reviewed research publications and going through it in detail so you don't have to read the paper. Now that doesn't mean you shouldn't read the paper, but you can watch the video clip of me presenting this information from an overview perspective. We'll try to make it clinically relevant and patient relevant at the same time. For those of you that are new to this is our 10th video. And we have about 150 to 160 papers that we will be going through. So if everything goes right, over the next 3 to 4 years, you'll see these out on our YouTube channel. So without further ado, we're going to go through this week's presentation. I've chosen one of our non-randomized clinical control trials that was published in 2002 in the Archives of Physical Medicine and Rehabilitation. Now this paper is very dear to me and my colleagues. This is one of a kind when it came out. In fact, it still is kind of one of a kind. At this time in 2002, we were one of a handful of authors as chiropractors to ever make it into this prestigious journal, the Archives of Physical Medicine and Rehabilitation. Right? So this is a non-randomized clinical control trial where we looked at chronic neck pain patients and they had loss of the cervical lordosis. We looked at a new method on its effectiveness at rehabilitating the cervical lordosis towards normal values and also the potential effect on chronic neck pain. And you'll see why I say potential effect. Due to the study design, we could not make strong conclusions about this method and how it affected chronic neck pain, but we can make strong conclusions on what it did to the cervical lordosis. So without further ado, we're going to go through this publication. First and foremost, introduction and background. We need to understand that loss of the cervical lordosis is in fact a true health concern, both before 2002 and certainly after 2002. I've chosen a few studies to give you a little bit of a background and overview on the actual validity of why we would want to restore a cervical lordosis in a human patient, right? So when we look at the literature on this topic, there's many studies that are published, and I've kind of cherry-picked a couple of them to make a point. Now, you can always find studies that contradict what I'm going through here. However, the majority of information, and in my opinion, the better quality information, does indeed point to the fact that the cervical curve is important for a health outcome. This particular project comes out of the Journal of Neurosurgery Spine in 2009. I'll just read the title and the author. The lead author was Yoshida. It's cervical spondylotic myelopathy associated with kyphosis or sagittal sigmoid alignment. Now, sigmoid in this particular setting means an S-curve, either reversal in the upper or reversal in the lower with lordosis in the other regions. So what they did here is they looked at 43 patients, 30 men, 13 women, with a mean age of about 60 years of age. These subjects had cervical kyphosis, or straightening of the cervical curve, or S-curves. And what they identified is preoperatively and postoperatively, the alignment of the cervical curve affects the outcomes of patients with cervical myelopathy. Now, if you're a patient, myelopathy means you've got spinal cord compression inside the canal of your cervical spine or in your neck. It's compression from a disc herniation and a bone spur, or both of them, right? So it's either one or the other or both. And when I put direct compression load on the spinal cord, it can affect not just your arm nerves, but it affects the nerves that go down to the bowel and bladder. It can also affect the nerves that go down your leg. So people will get numbness and tingling or sensory and motor disturbances in their lower extremities, meaning You walk funny. You can't pick up your foot. You can have a foot drop. Oftentimes, this can come from the cervical spine or the neck. People associate with the low back, but in fact, it's actually very common to be coming from the neck. So these are the types of patients the surgeons are working on. Now, what they'll do is they go in and they do a decompression, they remove the disc and they remove the bone spur, and then they look and see what the outcomes are after surgery. This particular project, here's what they identified. Kyphotic deformities put mechanical stress and strain on the cervical spinal cord, leading to neurological dysfunction. In our group of patients, anybody that had a kyphotic or sigmoid deformity of more than 10 degrees, what happened is these were the ones that they could not get adequate decompression of the spinal cord. These are the ones that ended up having sustained poor outcomes after the surgery. These are the examples of the types of neck curves that they were looking at. A is a complete kyphosis, B is a sigmoid reversal down low, and C is a sigmoid reversal up high. Anytime these three necks were associated with more than a 10-degree reversal of the cervical curve, these are the ones that had a poor outcome. Next paper, Grosso et al. Same journal, Journal of Neurosurgery Spine, but a couple years later, 2013. Here's what they identified. Reversal of the cervical lordosis can lead to mechanical pain, nerve dysfunction, and functional disabilities. In these patients, 36 of them, followed 2 years after surgical decompression, what they found out is both segmental, meaning each individual segment, if it was kyphotic, or total kyphosis, affected the neurological status of patients post-surgically. Shown as a picture on this slide, this comes from Bill Ruck's book, and Bill Ruck's book was originally published in 1997 from CRC Press. Okay, this textbook is called the Atlas of Subluxations of the Human Spine and Pelvis. And what I did is I took a photograph out of Bill Ruck's book showing a cadaver cross-section through the sagittal plane, and you can see the spinal cord here. Here's the brainstem, spinal cord. Here's the cerebellum, or the back of the brain area. This is the top of the neck, called C1, C2. Here's C3, C4, C5. Here's the disc at C5, C6. That shows a herniation. And you can see it's putting mechanical load on the spinal cord. When you lose your neck curve, either segmentally or totally, it's going to affect the mechanical forces on the spinal cord. When you have a disc injury, a disc herniation, that now is going to increase the load on the spinal cord, and it can reach 30 to 40 pounds per square inch at that contact point. That's a huge amount of pressure. That's the pressure in my truck tire. I have a 3-foot truck tire. That's the pressure in my truck tire acting on your spinal cord. It creates problems. This is not good for you. Okay? You have to put this in perspective. Many, many people will suffer from this disorder. You don't realize the consequences until you're going through it. It may actually remain hidden until the late stages. Here's what the surgeons do. They go in there, they try to remove that disc, but you know what? If they don't correct the alignment of the spine, you end up with long-term problems. That's what this paper in 2013 identified. Last paper in the background. This one was the first ever of its kind in 2011. This is a double-blind, randomized clinical control trial where they're looking at the outcomes after cervical spine surgery from an alignment point of view, seeing if segmental or total kyphosis of the cervical spine fusion, if that affects patient outcomes post-surgically. Lo and behold, what they identified is the segmental alignment of the fusion as well as the total alignment of the cervical curve will affect patient outcomes, such that people who had better cervical lordosis had better outcomes on pain, disability, and the SF-36 physical component scores. And that's what this says here. Neck Disability Index and the physical component score of the SF-36. So in other words, surgeries that try to maintain the cervical lordotic alignment as well as the segmental fusion in lordosis, these achieve better outcomes. So that brings us into our current paper. We now realize with this little bit of a background There's validity for the concept of the cervical lordosis, or loss of the cervical curve, adversely affecting human health potential. Okay, so chronic neck pain patients is what we're studying in this population. What we did is we chose subjects that had a long-term history of neck pain, or who had a history of at least 3 months or more of this duration of their neck pain. All these subjects also had to have loss of the cervical curve. The cervical curve was defined as abnormal when it was at least 25 degrees from C2 to C7 or below. Most of the subjects were well below that. So if you look at this, there's only 9 subjects that were between 16 and 25 degrees. 21 of the subjects were less than 16 degrees. This is truly a hypolordotic population. Ideal values for the cervical curve are anywhere from 30 to 42 degrees. Okay, so we're talking about a population that's well below that. So these are 30 prospectively selected patients, meaning we knew we were going to do the study in advance. We selected these people, they fit our inclusion criteria, and we asked them to volunteer for the intervention group. Here's what we did. We did initial spinal manipulation using diversified technique for the cervical spine, and we did this bilateral. We didn't do a segmental specific adjustment like some chiropractors might do. We did generalized spinal manipulation bilateral using a modified diversified technique. Okay, they received that for 2 to 4 weeks. They also received Pope two-way extension 3-point bending traction. We call it Pope two-way because Dr. Mike Pope of Troy, Ohio, was the originator of this type of traction. He designed it in the late 1980s after training under my father. Dr. Mike Pope is now retired, and he actually still resides in Troy, Ohio. I'll show a picture of the traction unit coming up. Traction was applied 3 to 5 times a week for 8 to 10 weeks for an average in our population of 35 visits per person. So we've got 35 visits over the course of 9 to 12 weeks, meaning the average person, if you looked at 10 weeks of treatment, got 3.5 visits per week. Afterwards, we did a second examination, including pain and x-ray, and we waited a minimum of 1 day after their last traction session. So this is important. We don't x-ray somebody immediately after traction. We x-ray them a minimum of 24 hours later so the spine can recover after the loading cycle. We matched these people to a prospective group that decided not to do care for their condition. Now, both groups have chronic neck pain. Both groups have loss of the cervical curve. The control group self-selected to do no care. Interesting. Patients come in, but yet they don't really actively want to do treatment. So in this case, we said, you're a candidate for our study. You've elected to do no care. Would you, volunteer for the control group in this study we're doing? And of interest, 25 subjects actually did that. The requirements were they had to maintain what they were what they had done in the previous few months. So they couldn't change their treatment regimen. They couldn't go seek another chiropractor. They couldn't change medications, etc. So they had to continue doing what they had been doing in the previous months before they came in. That way we can truly see the natural history of this neck pain group. Then we're going to call them back in approximately 8 months, and we're going to reevaluate them to see what their neck curve and what their pain intensity looks like. Why do we wait 8 months in the control group versus doing a 10-week reexamination in the treatment group? Well, the fact of the matter is we wanted to extend this out as long as possible so we can truly see what the natural history of chronic neck pain is. If I wait 10 weeks, I don't really know, is this person going to, still continue to be chronic, later on. But if I wait almost a year, I can look at these people and I can say, wow, doing nothing for this condition, didn't benefit the person. They're the same. So that's what we hypothesized, and we'll see what happened. Outcomes. We looked at before and after visual analog pain scores. And then we looked at radiographic measurements. Now, the x-rays were taken in the same manner, and they were taken by different examiners, by the way. My wife and I were the treating clinicians. on this particular population. We did not do our own examinations. We had an intern exam doctor that was blinded to whether or not the subject was in a study or not. They were doing the examinations, both initial and follow-up. So this is a really good study design. Non-randomized means the patients self-select themselves into what group they want, and then we have a blinded examiner who's doing the examinations versus the treating chiropractor. You know, if the treating chiropractor does the exam, we might lead the person, you know, towards a certain scenario unintentionally, so we tried to remove that from the equation. We also then, what I should go back to this and show you here, is the treatment group, after their 35 sessions, we stopped care totally, and then we followed them for an additional 15.5 months. We wanted to follow them and see what happens when they do nothing now for approximately a year to 1.25 years. And they're not going to do any care, no maintenance chiropractic care, no home traction, and we're going to see what happens to any correction that we achieved and what happens to their neck pain. 25 out of the 30 subjects made it to the long-term follow-up, which is pretty good, 83%, right? So we had a 17% dropout. So we're looking at all measurements of the cervical curve. We've discussed these before. We do segmental and total angles of curve, and then we do posterior body lines and also Cobb cross-sectional in-plate lines. We report both because many doctors out there do both, so we wanted to report both types of measurements. Here's the Pope two-way traction that was really the meat and potatoes of the treatment. This is really what we're investigating in addition to the spinal manipulative therapy to the cervical spine. The two-way traction, you can see it has a front pole, and that front pole must be located at the apex of the person's abnormal cervical curve. So shown here is an abnormal cervical curve that starts becoming straight or kyphotic down in the lower cervical spine from C5 to C7. So that's the location of my strap. I'm going to pull down in that region. Now, if my location of my reversal was in my middle cervical spine, we would take the angle of this front pole and we'd elevate it up about 10 to 20 degrees. Okay, so depending on the shape of the neck, that will dictate what part of the neck we pull on with this front load. And then the back load that we have here going on is either directed vertically or horizontally or somewhere in between, depending on the patient's tolerance for extension. Now, these patients did not have radiculopathy and stenosis, so we can get away with a little more extension in the cervical spine. Had all these subjects been, stenosis or radiculopathy patients, we'd have to apply a little more distraction than what you're seeing here. Okay, so how do we start with traction? Well, number one, we start with 15 pounds on the front weight. So we have 15 pounds over this pulley here. We start the person at their tolerance 1 to 3 minutes. The next session they come in, we try to move that time up, and eventually we're trying to get the person between 10 and 20 minutes of traction. 10 to 20 minutes of traction is what it takes to physically remodel or deform the spine tissues back towards a proper shape. This is why traction is effective for the cervical curve. Excuse me. So what we want to do is once we get to 10 to 20 minutes, we're going to increase the weight. 15 pounds is not enough to physically change the adult cervical spine. So ideally, we want to get the patient up to a minimum of 25 pounds on the front load and up to 40 pounds on that front pole. So it's a slow process. It's consecutive visits. We're increasing time and we're increasing weight and we're going at patient tolerance. Now the key is you have to work within the patient's ability. Certain straps like this one can load the job more than some of the other straps. So if the patient is sensitive, if they have temporal mandibular joint disorders, you have to modify the strap and modify the setup. So please understand that there's a whole art to working a patient through this. We do a lot of training for our doctors in this particular technique. In fact, I teach a 12-hour course on how to properly do neck traction for different patients. Results. Here's our our control group comparisons versus the treatment group. And what you're looking at is, are the two groups matched? So the control group is in the first two columns. We have the mean and standard deviation. And then my treatment group is in the next two columns. And then the p-value, looking at differences between the two groups using a two-sided two-sample t-test. Okay, so what we identified is The age. Our subjects are matched for age, P greater than 0.05. Our subjects are matched for height, P greater than 0.05. Our subjects are matched for weight. Our subjects are matched for pre-pain intensity, P greater than 0.05. However, at the end, the control group, 8.5 months later, they still have about the same amount of pain as when they started, 3.5 versus 3.6, versus the treatment group. We're seeing statistically significant differences in the treatment group subjects. Okay, so you have to keep that in mind. Now, females, we matched the male to female ratio. Okay, we matched the age in the subjects, and etc. So you go down, males versus females. You can see that there's no statistically significant differences, and this is an important component. Now, what you will notice here is the women tended to have more chronic neck pain than the men, and that was on average in our treatment group, and that was statistically significantly different. That's why we're categorizing the results based on men and women, because there is a difference in the amount of pain that women had versus the men. Okay. Results for the control group x-rays. Okay. This is the initial x-ray compared to the follow-up with no care. So no care 8 months later, and we see the pre-x-ray means in this column and the post follow-up 8 months later after no care. And what do you notice? Here's the difference between the variable. 1.1, that's millimeters, that's no change. 0.4 millimeters, that's no change. 0.7 degrees, that's no change. 0 degrees, that's absolutely no change. 0.5, 0.4, 1.0, 1.1. You have to reach at least a 1.5 to a 2 degree difference to see statistically significant findings. And you'll notice that the control group's x-ray measurements look exactly the same as when they started. Okay, and I'll tell you what this means coming up in the conclusion. In contrast, here's the treatment group before and after x-ray. So this is the subject that got spinal manipulation and got the cervical traction. You'll notice that we see statistically significant differences in the before initial and the after treatment x-ray. And this is a big deal. We're seeing a 14.2 degree total change in the C2 to C7 lordosis. That's right here. That's a huge change. And then segmentally, we see each region of the spine is statistically changing except C6, C7 of interest. Okay? If you'll note, this one was not as abnormal to begin with as some of the other segments in the lower cervical spine. So if you load the low neck, it's possible that that C6 to C7 joint is not going to extend as much. That's what this means. Okay? There's other ways, to increase the segmental angle at that joint if you need to, and that might be a different topic that we go through later. Okay? Still, 14.2 degree change in 35 visits. This is huge. At this time, this was the biggest reported conservative change using proper techniques to change the cervical curve that had ever been reported. The only ones that were able to achieve at least this or above were surgical outcomes. So this was a big deal in 2002. In fact, it still is a big deal today. 15.5 months later in the treatment group, with no care, 25 of the 30 subjects come back. Here's what we find. So here's my follow-up x-ray after treatment, so I have correction, and then here's my 1.5 year follow-up, and we see we've lost just a couple degrees of the curve, but it's still mostly maintained its correction. We've maintained about 75% of the change in the cervical curve with no care. This is huge. What this means is for most people, we see stability of this correction. Now, they did lose a little bit, so it implies that you have to do something to maintain this improvement. However, for the most part, it's reasonably stable, okay? Now, you'll notice if you look at the mean and standard deviation, they're a little bit different between the initial one and the follow-up. So if I look at this, 26, 13.3, 22.9, 13.5, what we're seeing is you got to realize these are a subset of this 30. This is 25 out of 30. So it's going to be different than the entire sample that we showed in the previous slide. So you have to realize the previous slide was all 30 subjects. This is 25 of those 30 subjects. So you notice their mean and standard deviation might look different on the last slide, just in case somebody's wondering, and if you're nitpicky like me, you want to know why that is. Well, it's a subset of our population. Okay, still, important finding. We find that the majority of the curve is maintained even with no care. Example, patient outcome. Here's a kyphotic mid-cervical spine, just like in the surgical papers that I went through earlier. If you have this kind of alignment, you're the one that's going to have poor long-term outcomes. Well, we can change that conservatively. Look, this is after traction. We've got a much better alignment in the cervical spine. Now, I'm not saying that this person's neck is now ideal. It's not. Ideally, this person would need more care. However, they're part of a research project. They have informed consent that they read through and they signed. This project is IRB approved. We followed all ethics with human research. And so as part of this design, this person now, as part of the study, they have to stop care. Now, if they don't want to do that, if they want to continue care, then they can't be in the study. Right? So this person knows that to begin with. So what we're going to do is we're going to stop the care at this middle x-ray, and then we follow them for almost 1.5 months, right? 1.5 months from the beginning of the study, about 15 and a half months from the follow-up x-ray after the treatment. And you can see that this person maintained their correction very nicely. Here's an example of somebody that didn't come in for the long-term follow-up. We have a pre and a post after 35 sessions, but we lost this person a long-term follow-up. Don't know what their curve looked like at 15 months because they didn't show up. Remember, 17% of the people didn't come back in. Hopefully, that's because they were still doing great, but we don't know. We really don't know. But you can see a remarkable correction in the shape of their cervical curve and the magnitude of the curve. Very nice. All right, so discussion. Number one, as I said, when this paper came out, this was the largest conservative correction of the cervical curve ever reported in the clinical literature for conservative care. This is a big deal. Number two, you might think that the spinal manipulation was really what improved the pain in these subjects, because we did do 2 to 4 weeks of diversified spinal manipulation. However, when you look at the literature on diversified spinal manipulation or spinal manipulation in general, the average person with chronic neck pain only improves by about 40 to 45%. We actually did a comprehensive literature review. We had that published in 2008 and 2009. I will go through that paper later on these videos, but I'm here to tell you right now, if you look at that literature, the average person with chronic neck pain is only 40 to 45% improved. If you look at our study results, this current study in 2002 that we're going through, we got about a 70% improvement in chronic neck pain. And I'm here to tell you that's different. Okay? It is not strictly due to the spinal manipulation. Spinal manipulation alone will only achieve for a 40 to 45% improvement in pain intensity. What about the rest? Well, this trial shows that with 35 visits, with doing this traction that improved the cervical curve, we got 70% improvement in chronic pain. And by the way, it was maintained at long-term follow-up with no care. Many times the people in standard manipulation studies, they slowly start to progress back to baseline values, and you can look that up for yourself. Now, problem number two, you might think, well, because we did spinal manipulation diversified in the initial 2 to 4 weeks, that might be why the cervical curve looks better. No way. Absolutely not. The literature does not support that. Now, once in a while, like 1 out of 50 or 1 out of 100, a blind squirrel finds a damn nut. And you're going to get lucky and you're going to correct the neck curve by doing, the old rack and crack. But I'm here to tell you on average that doesn't happen. We already know the clinical trials in the literature show that spinal manipulation on average does not, let me rephrase this, does not change the cervical curve. We know that. We've done that in our previous study in 1994. Other projects have done that. Plogger et al. 1990, JMPT, and also Hurwitz et al. Did that in spine in a literature review. You can read that paper, and they reported no clinical trial showing that this type of spinal manipulation that we used is able to change the cervical lordosis consistently. What does that mean? The group means the average change comes out to nothing. So we can immediately squash that argument. It's not the spinal manipulation that changed the curve. It is the traction that we're doing. And if you're logical and rational with this, you'll agree to this, okay? So conclusion, 3-point bending cervical traction combined with some diversified spinal manipulation produced statistically significant changes in the cervical curve. We're here to tell you that it was really the traction that made the change. That's not to say that the manipulation wasn't of value. It's just to say it's not what made the change in the curve. The lordosis increased an average of 14 degrees. At 15 months follow-up with no care, the lordosis maintained most of its correction with only a 3.5 or so degree loss, about a 25% loss of the correction, meaning maintained 75% of correction. For the control subjects, we found no statistically and no clinically significant change in their pain or their X-ray alignment. Now, this is an important conclusion. Because the control group was identified to have no change in their chronic pain and no change in their alignment, here's what we can specifically conclude. Number one, neck pain does not improve on its own. The idea that your neck is just going to get better, just wait it out, that's crap. Most people out there can tell you that their neck pain goes up and down and up and down, and the average stays the same, if not slowly gets worse over their life. If it's true chronic neck pain, it doesn't get better. This is a bad deal for these people. However, it's a good deal for the control group. Or the treatment group. We showed we can improve this compared to the natural history. Now, number two in the control group, X-ray positioning is repeatable and reliable. This is a big deal. We can take different examiners who X-ray the same subject at different intervals, and they find the exact same thing. This means X-ray techniques are repeatable. Very, very important. The curve just doesn't change magically on its own, right? One minute you're kyphotic and the next minute you're lordotic. That doesn't happen. What you have is what you get unless you have a trauma or some kind of intervention to change it. And then the third and final thing, this shows that X-ray line drawing techniques are also repeatable and reproducible. In order for me to get the same finding of the neck curve alignment, my X-ray measurements have to be reliable, repeatable. We've already shown that in previous projects, but this also demonstrates that. This set of conclusions, very important that you understand from this particular project. Okay, great. Hopefully you enjoyed that overview of this 2002 clinical control trial that we did for CBP technique. If you're a patient out there and you're suffering from chronic cervical spine disorders, before you consider surgery, unless it's an emergency, why don't you look up a CBP, Chiropractic BioPhysics trained provider? You can find these trained doctors anywhere in the world on our website, www.cbppatient.com. Look for the certified ones, and if you cannot find a certified one, look at the ones that are in your area, call them up and ask them if they do this type of cervical spine traction to correct the neck curve, because that's what you want. You want somebody that's going to work with you to improve your alignment, which is going to improve your health and your pain and your disability. After all, you don't want to suffer like this. You don't want to be this person that has chronic neck pain. There is an answer in many, many cases. You just have to find the right provider. If you're a chiropractor out there, hopefully you enjoyed this presentation. Hopefully you learned something from it. You know what? And if you're not doing this type of work and you want to learn more about it, look us up online. Go to idealspine.com. We have seminars where we train chiropractors. We also have products and equipment that we teach you how to use properly, how to select people for it, and then put these people through a program of corrective care, and you can too achieve the results like we've shown in this clinical trial. It is repeatable, it is reproducible. That's the point of doing research. That way you can go back and use this and you can go, wow, I'm actually doing proper evidence-based care. The last thing is, if you're out there and you want to support good quality chiropractic research like this, help us out. Donate to our nonprofit organization. The only way we can do trials like this is if we get financial help and assistance. The average clinical trial costs a lot of money. You're looking at $50,000 to $100,000 for most clinical trials that are out there, if not more. CBP Nonprofit, we do this research on much less than that. We actually do our average trial on probably $5,000 to $10,000. We still need your support though. You can support us directly by going to our website and directly supporting and donating to Chiropractic BioPhysics Nonprofit. Or you can support us indirectly through Amazon Smile. Just select CBP Nonprofit or Chiropractic BioPhysics Nonprofit as your nonprofit organization when you make a purchase through Amazon. Hopefully you enjoyed this week's research presentation. Until next time, I'm Dr. Deed Harrison. Enjoy your week.